Hello and welcome to Pulse Check with Archer Nursing, where nursing comes to life. In this podcast, you give us 15 minutes of your day, and we'll take one complicated nursing topic and make it easy. Ready for nursing to be fun? I'm Morgan, and today we're tackling superior vena cava syndrome. This is an oncologic emergency that shows up in a really dramatic, in-your-face kind of way, literally. So with all that said, let's jump into our practice question as always and get things started. A nurse is caring for a client with a history of small cell lung cancer who was recently diagnosed with superior vena cava syndrome, which assessment finding requires immediate intervention by the nurse. We have A, non-productive cough and mild dyspnea on exertion. B, periorbital edema and tightness of the shirt collar. C, distended veins over the upper chest and neck. And lastly, D, new onset stridor with difficulty swallowing. Think about your answer and we'll come back to it at the end of the episode. First, though, let's get into what superior vena cava syndrome actually is. And before we talk about all those scary symptoms, we need to kind of zoom in on the plumbing. I'm talking about the highway back to the heart. The superior vena cava is a large, short vein that sits in the upper chest just to the right of the sternum, and its job is simple but critical. It collects deoxygenated blood from the head, neck, and upper extremities and the upper chest, and then it delivers that blood back into the right atrium. So it is the last blood vessel connecting our body to our heart. We basically get the veins from the face, scalp, brain going into the internal and external jugulars, and then they drain into the SVC, the superior vena cava. Then we get the veins from the arms and upper chest. They drain into the subclavian and brachiocephalic veins, which go into the, you guessed it, SVC. So everything from up top, draining eventually into that SVC, which goes into the right atrium, of course, then to the lungs, gets oxygenated, and pumped right back out to the body. And that's why I called it the highway to the heart. You can think of it like a big interstate highway that funnels all the traffic from the upper half of our body right into that right atrium. Now let's get into the juicy stuff here. We've got this highway to the heart draining all of our blood, and in SVC syndrome, superior vena cava syndrome, we get a massive traffic jam in that highway. So it's like the on-ramp to the highway, getting into that heart, boom, 12-car pileup, and then everything upstream backs up. So everything draining from face, neck, arms backs up and can't get into the heart. Everything else below, like the inferior vena cava, legs, everything draining down there, it's still cruising along, okay? So upstream, we're blocked. Downstream, we're still just fine. Now, when does this happen? Why would we get a blockage in the SVC? It happens when there is complete or partial obstruction, either from an internal or external source. Whatever it is stopping blood from freely draining into the right atrium, which causes pressure to build up in all the veins that feed into the SVC. That increased venous pressure is what gives us our classic symptoms, okay? So think lots of blood up top. Our face, neck, and upper extremities are going to be swollen. We might have distended neck veins. We might feel really full or have a headache in the head, dizzy visual changes because of all the blood up there. Now in the lungs, dyspnea, a cough, really hoarse, having wet lungs. And in the worst case, this progresses to laryngeal edema, causing stridor and trouble swallowing, and even progressing into cerebral edema, which can alter our level of consciousness and cause confusion. So hopefully that all makes sense. Pretty straightforward. We have a blockage leading into the right atrium of the heart. Everything upstream of that gets really full of blood and swollen. That leads to the swelling, face, head, neck, all of those symptoms we just talked about. But what causes the blockage? All right, the SVC sits in a really crowded area in the mediastinum. We've got the right mainstem bronchus, the trachea, the aorta, lots of lymph nodes here. So any mass in this crowded, tight area can squish the SVC, kind of like someone stepping on or kinking off a garden hose. The most common culprits are lung cancers, lymphomas, and metastatic tumors in the mediastinum. So that's why at the beginning I said SVC syndrome is usually an oncologic emergency. We've got some sort of mass, usually it's cancer, and it is squishing that SVC. Now, it is important to note that we do have non-cancerous causes. They're just super rare. We could get a thrombosis inside the SVC. That could be from a central venous catheter, a pacemaker lead, or an implanted port. Even more rare, we could have fibrosing mediastinitis. So just think anything blocking that SVT. And the blockage can be external compression from like a tumor or internal obstruction from a clot or a tumor inside the vessel. I can almost guarantee if you see something about SVC syndrome on one of your exams or the NCLEX, it is going to be from a client with a cancer that developed a mass, and that mass squooshed down on the SVC and caused the blockage. And that blockage is, of course, then what causes all of our symptoms. All right, we get obstruction at the SVC, so blood can't get into the right atrium. Blood then backs up in the jugular veins, subclavians, and that causes our JVD, our distended chest wall veins, our facial and periorbital edema. So your client might say, my eyes look puffy or my necklace is too tight, because all of this is getting edematous with blood flow backing up. It causes increased pressure in the veins of the upper airway, which is what can lead to laryngeal edema, hoarseness, stridor, cough, and dyspnea. And lastly, most scary, increased pressure in the intracranial veins that increases our ICP, and it can cause headache, blurred vision, dizziness, confusion, or decreased level of consciousness. And keep in mind, this is all top heavy, okay? Because the inferior vena cava is totally fine. So we've got a swollen upper body, but like below legs, that's looking pretty relatively normal. So let's take all that info and go through a good old case study. You're going to be on the oncology floor today. And of course, you have a 58-year-old male with known right-sided small cell lung cancer. He was admitted overnight for increasing shortness of breath and facial swelling. You're coming on at 7 a.m. for day shift. You walk into the room and notice a few things right away. His face looks puffy, especially around the eyes. That's called periorbital edema. His neck veins are bulging, so that's JVD. He tells you his wedding ring feels tight, his chest feels swollen, and on exam, you see he's breathing a little bit fast. Now, he is still able to speak in full sentences and swallow. His airway's not obstructed, but overall, he doesn't look great. So think about those symptoms and how they connect back to the anatomy of SVC syndrome we just talked about. He's got periorbital and facial edema. That's from venous blood of the head and face being unable to drain since the SVC is partially blocked. He says his chest is tight, his wedding ring is tight. Well, that swelling in the neck and upper extremities is from elevated venous pressure, again, because the SVC cannot drain. He's got mild dyspnea and a cough. Remember, again, the SVC is sitting right in that crowded mediastinum space near the airways, that right mainstem bronchus and tracheal. So he's got pressure pushing on his airway and vessel, making it harder to breathe. So this is a pretty good reason for your client with lung cancer to be admitted, at least for observation. You're going to go ahead and get a full set of vitals as you do this assessment. You see a heart rate of 102, a BP of 132/78. Respers are at 22, and an oxygen saturation of 93%, and he is on 2 liters nasal cannula. So think about those vitals. Is anything screaming at you? Not really, honestly. Yeah. He might be a smidge tacky. His blood pressure's slightly higher than I would love it, but nothing in here is jumping out as like, this guy is about to code. We've got to do something. All right. So you've got his vitals, you've got his assessments, you've got 4 other patients. So you're going to go do your rounds, and then we'll jump forward here. A few hours into the shift, you go back for your second assessment. And now you're going to notice something new. His voice sounds hoarse. All right. He tells you he feels like his throat is tight. His respirators have bumped up to 32 per minute. And as you auscultate, his upper airway has this faint, high pitched sound with inspiration. What do we call that sound, everyone? Faint, high pitched sound with inspiration. You should be thinking stridor. And when you hear stridor, you think airway emergency. Okay, what's going on here? We've got a tumor compressing that SVC. It is squished. Venous pressure is increasing in all those upstream veins, including those around the airway. And that has progressed now to laryngeal edema, stridor, and potential airway obstruction. Do we now have an emergency? Yes, absolutely. What do we do? How do we prioritize? Number one, in SVC, we are positioning the head of the bed up. Our first move here is raise that head of the bed as high as he can tolerate, high Fowlers. This is going to help us decrease venous pressure in the upper airway and reduce edema in the airway and brain. We just want to let gravity drain whatever we can. All right, so we've got him positioned up there. Following our ABCs, we know we have to address the airway first. He's got stridor. He is still moving air. It's not completely blocked, but we are going to do what we can to help. We need to increase his oxygen, staying within our ordered parameters, but we want to go ahead and bump that up as we call for help and escalate the situation. So the take-home message, hoarseness and stridor in a client with suspected SVC syndrome means potentially we have an airway compromise. A for airway, ABC. Airway is the priority. So we are calling the provider, notifying the charge nurse, and very clearly articulating we are concerned about this client. We have new onset stridor. So the provider is going to come in. They're going to figure out what we can do here. In this case, a stat CT was ordered, as well as IV steroids to help decrease the inflammation and edema. As the nurse, the biggest thing you can do, you've already done with positioning, get that head of bed up, and you're going to keep a very close eye on that airway. And secondly, for neuro changes, because elevated venous pressure can lead to cerebral edema. You gotta watch out for a decreasing level of consciousness, a change in orientation, headache, vision changes, any of those things, red flag, notify your provider. So those are our immediate priorities in SVC syndrome. We're raising the head of the bed. We are escalating the situation, getting help so we can manage that airway. In this client, they did a stat CT and then immediately started high dose IV steroids to get that inflammation down, and then scheduled him for urgent radiation to shrink that tumor. And by shrinking that tumor, we kind of unkinked the garden hose there, relieved the traffic jam, so to speak, and the swelling gradually decreased. That blood was able to drain back in to the right atrium. Now, he's still going to need all of his long-term cancer treatment and management. This is not fixing his lung cancer, but the acute complication of the SVC syndrome is heading in the right direction with getting the size of that tumor down so it's not compressing that large vessel. So for you as the nurse, what do you prioritize? Make sure you recognize those early cues. facial and periorbital edema, tightness of the clothing on the upper body, JVD, etc., and especially stridor. If you hear stridor, you need to elevate that head of the bed and notify your provider. We have got to maintain that airway and get that swelling down. So with that being said, let's circle back now to our practice question from the beginning of the episode and see if you can get to the right answer and understand why. A nurse is caring for a client with a history of small cell lung cancer who was recently diagnosed with superior vena cava syndrome. Which assessment finding requires immediate intervention by the nurse? We have A, that non-productive cough and mild dyspnea on exertion. B, periorbital edema and tightness of the shirt collar. C, distended veins over the upper chest and neck. Or D, a new onset stridor with difficulty swallowing. So again, which of those assessment findings require immediate intervention? Hopefully you said D. I'm sure you all did, because stridor and difficulty swallowing means we have an airway problem. A, B, C, we prioritize A for airway. All of these symptoms are things we could absolutely see, and they're all concerning, but D is the most immediate priority. And what do you need to do? Elevate the head of the bed, stay with the client, and call that provider. Your big takeaway here is that when we get obstruction of the superior vena cava, we have impaired venous return from the upper body, and that causes edema, congestion in the face, neck, upper extremities, and even leading to airway obstruction and increased pressure in the brain. Worsening upper airway status and neuro changes are your drop everything priorities when it comes to superior vena cava syndrome. So recognize them early, sit that client up, and escalate fast. All right, future nurses, that is a wrap. If you found this pod helpful, I'd love to continue supporting your nursing journey through nursing school, the NCLEX, continuing ed, and beyond. Archer Nursing has you covered with on-demand video lectures, high-yield question banks, live case study reviews, and so much more. We want to help you master tough concepts and make it fun. So join us over at archerreview.com. Follow us on socials at Archer Nursing for more free nursing tips and study resources. Thanks for tuning in to Pulse Check with Archer Nursing. I'm Dr. Morgan Taylor, and I'll see you back next time.